Thank you, Dr. James Barone, for giving a program director's perspective of surgical training in the U.S. You are or were a program director, right? Can you give a little bit of background?
Yes, I was a program director for about 24 years. I was at a small hospital in New Jersey as a chairman of surgery and program director, and then I moved to Stamford, Connecticut for almost 14 years and also ran a residency program and was a chairman, and then finished up my academic career at Lincoln Hospital in the Bronx, which again, I was chairman of surgery and I was the site director for the surgical program. We had rotating residents in from other places in that particular hospital. And
Good.
then for the last 4 years until I retired, I got out of the education business and was just doing general surgery.
Okay, great. Can you just give a bit of a brief description of how the U.S. system works in terms of training surgeons for a global
Yes,
audience?
it goes like this, and it is slightly different than I think most foreign countries because we generally most physicians do 4 years of college and then 4 years of medical school, and this is different. And so, as you probably know, in many countries it may only be a year or two of undergraduate work before medical school, but we do a full 8 years before graduating from medical school, and then everyone does a minimum of 3 years of residency training if one wants to be a specialist of any kind. And general surgery in the U.S. takes 5 years. Many people do a year of research to make it 6 years. And then a lot of the graduates, more than half these days, and it may be as high as 80%, take fellowships for yet another year. So to become a general surgeon with fellowship and a year or so of research could be another 7 years. So that is a 15-year odyssey if you do it the long way.
Right, right. And in your years as a program director, what were the biggest changes you saw in how training was accomplished for surgeons in training?
Well, I think the changes were many. When I started out in 1971, graduating from medical school, uh, there were no such things as CT scanners or ultrasound machines, for one thing. So we certainly adjusted as the years passed to the technology. And as you are obviously aware, in the last few years, the technology has really boomed, and including in the U.S. at approximately mid to late 1990 was the advent of laparoscopic surgery by general surgeons for not just taking a peek, but actually therapeutic laparoscopic surgery. So that was, of course, a major change in the way surgeons in the U.S. are trained, and I'm sure everywhere else at this point in time. But we we certainly went through quite a bit of those kinds of changes, and other things like the internet and electronic medical records and all that really have changed things dramatically, certainly.
So technology and tools. How about the actual model itself in terms of how where residents got their education during their
Well,
training?
that's kind of interesting because I think a lot of this hasn't changed that much. I think that if I could take a resident from right now and transplant him back to 1973 when I was a second year resident, he wouldn't be too out of place. He might be a little aghast at the amount of hours we're putting in, but otherwise, it still kind of goes like, you take care of the patients, you scrub, you see the consults, you do things in the middle of the night. All that's sort of pretty much the same. And I think, by the way, the other major change, which I didn't mention and should have, was the incredible exponential growth of the amount of information that one needs to know to do any kind of medicine, but certainly surgery as well. We've kind of exploded the amount of information, and the amount of time to train residents, as you know, has decreased.
Right.
So it's been a big issue as well. So the amount of information being much more involved and detailed that one must ask the residents to learn over a shorter period of time. That's a big change.
Right. And so we've seen changes in how we communicate, changes in tools, and we've had a decrease in the amount of time that residents have to train. Based
Right.
based on the imposition of an 80-hour maximum work week. Um, so if we're thinking about how to change our surgical training system, what portions of the training system that you're familiar with are important to keep, and which aspects need to change?
Well, I think we certainly need to keep the hands-on experience and, in fact, increase it. Many recent papers have shown that graduating residents, in many cases, at least 25% or so of them, lack the confidence to go out into practice after 5 years of training. And a lot of that appears to be based on just not getting enough operative experience. So clearly we need to not only keep that, we need to somehow find a way to increase it. And by the way, I have concerns about that because expanding residency programs, which is going on right now, and people establishing new programs, I think is even more likely to dilute the experience that today's residents are having. And I think that's a real problem that has to be watched by those monitoring and running training programs. So that's a problem that we need to get over quickly, and that is giving the residents more experience. And I think the other thing, which is another change that I just thought of, is that when I was a resident, we would operate and the attendings would be at home in New Jersey or Westchester County, which, as if you know the New York City area, could be 25 or 30 miles away. And we did a lot of things in the middle of the night that were unsupervised by an attending. The chief resident would take third or fourth year through a big case, and those days are completely gone as far as I know, except perhaps for a few programs. The amount of independent work that residents are able to do is really almost nil. And that isn't good, because when they get out on July 1st, they are then responsible, and they've actually never done anything by themselves,
Right.
which is a little bit tough. You know, it's like asking a pilot to do a lot of training with somebody else in the cockpit and then start flying passengers around the next day, you know, after a suitable amount of time. And that is, I think, not a good situation. So because of medical legal issues and risk management issues, the amount of supervision that residents have is in other words, I think what we need to do is find the correct balance between supervision, which I recognize certainly is necessary, and autonomous work by the residents, which is also necessary for them to actually become full, fully trained surgeons. So I think that's another area where we need to really somehow deal with it, and I don't know how. I wish I did, because if I did, I would let people know my crazy ideas, but I don't have any solution to that problem. So I think that is definitely an area that we need to work on. And something which really needs to change, in my opinion, is that we continue to teach and test residents on the old-fashioned model of, memorize this, memorize the three branches of that, what nerve innervates this. A lot of rote memorization where nowadays, I could pick up this little guy right here, my iPhone or any other smartphone, and I can get all that information. And I think what we are failing to do is teaching residents and medical students how to actually think, how to synthesize an idea. And I think we've all known doctors who are what you would call book smart. They can answer any question on a test. They, pass the written boards with flying colors. But you give them a warm body at 2 a.m, and it's a little different story. So we got to figure out how to get the residents to think, and I think it starts in medical school, because speaking of dropping people back, I know that if I were to take medical students from 1968 or 9 and bring them into medical school right now, there are some changes, obviously, but I think a lot of what goes on in medical school is very similar to the way it was 40 or 45 years ago. And I can tell you that when I was in every place that I had residents, I also had medical students. And we do surgical clerkship the way we used to do it 40 years ago. The students come, they hang around, they scrub, they maybe do a history and physical, and of course now they can't even write on the chart because it's all electronic, and they can't even write a history and physical unless it's on a piece of paper, which is of course, nobody's reading pieces of paper anymore. So they even have less involvement than they used to, and we test them the same way, a shelf exam and the usual, multiple choice questions, and whether they actually know how to diagnose appendicitis or anything else for that matter in real life is questionable.
Yeah.
I know there are OSCEs and there are tests like that, and a lot of schools do that, but I don't think the emphasis is on the right place. We're still emphasizing rote memorization, and we're kind of putting in the background synthesis of ideas and learning how to talk to patients, how to elicit information from people, what to do with the information when you get it, how to write work up tests, and then you can get into all these other areas like what test to order and how much does it cost. We don't talk about that with students at all. Usually, they come out of school just like we did in the old days, where of course we didn't really worry about cost because it didn't cost anything back in the old days. But now you got to worry about that, and they have to learn how to selectively order tests and not just order everything. So I think there are many places where education can be improved, the process can be improved. And I think the problem, though, is I don't see anybody doing much about it. I think that there's talk about things like this, but the people running the show, unfortunately, they haven't put me in charge. I'm available because I am retired. So if somebody wants to put me in charge of this, I'm ready. But
that was my next question.
Yeah, as yet the phone hasn't rung, and I did turn my phone off just now. So hopefully they're not calling me as we're speaking. But I kind of doubt that. So yeah, I really think that someone needs to overhaul the education system.
Right.
And I think many of the things
that?
I mentioned, I think eventually something's going to have to happen, but I don't see it happening tomorrow or within the next year or two because I don't see anybody doing anything.
Yeah, and that's my question. It seems like there are some pretty common sense changes. Need more cases, need to teach, as you're saying, teach other things besides rote memorization, teach judgment, synthesis of data, professionalism.
Well, let me interrupt you for 1 second. The problem with the more cases, if you look at the data from the RRC, the number of cases is actually going down for most things, and that's what I'm talking about by diluting experience. Now, if you pour more residents into the mix, there are going to be even fewer cases per resident. So open surgery is going to be a lost art if things go the way they are. And, we don't operate for most trauma anymore. And, where are they going to get the experience? And I don't think personally that expanding surgical residencies and finding new residencies or founding new residencies is going to help too much because, well, let me give you an example. Say you take Community Hospital X and you say, okay, guys, we want to make this a teaching hospital of the new medical school. How do you know that the surgeons there, or any of the doctors for that matter, are interested in doing that? Many people go practice in community hospitals without teaching programs because that's where they want to practice, and they don't want to teach medical students or residents. And now you're going to come in, and the administration is going to say, well, sure, we'll take the residents, we'd love them, or the students, or both. And then the staff is like, well, we don't really want that, and so they'll be sort of put in there. And who's to say that's going to be a great educational experience when it's a place that just by history and by attitude has never really thought about or even wanted to deal with residents and students? So I have grave doubts that that is going to be an effective way of dealing with things. And I don't have a solution for that either because it suggests that perhaps there's a finite number of places where one can have a residency. I mean, think about it. Around where you are there hospitals like crying for residents, saying, "Boy, could you possibly send us some residents?" I mean, I don't think it's happening.
What about when you talk about the dilution of experience? When I think about senior cases and all the cases that I am doing with residents who are never going to do an appendix, never going to do a hernia. In other words, going into other specialties. What about earlier subspecialization?
Well, I've always been against that, but I'm turning to a different. I think you're right. My perspective on this is changing because I think that because of what I've said, there aren't enough cases, and expanding programs is not going to solve the problem. I think the American Board of Surgery is going to have to look at this and say, well, maybe if people are going to, really want to be chest surgeons and that's all they want to do, maybe they don't have to do 50 lap choles or 100 to do that. And you could take that to any specialty of general surgery or subspecialty. If you're going to do vascular, maybe, and of course some of this has already happened with plastics and vascular surgery. There are shortened paths, but still, I think most people go the traditional way, and maybe that's got to be beefed up and changed completely to a system that would enable people to, and also get done faster. Because again, one of the many problems we face is that people have this enormous debt, and I keep seeing this number go up like every week. But the last number I read was something like $166,000 is the average amount of debt that a graduating medical student has, and of course that's an average. It goes from zero to 300,000, I suppose. But they could get started paying off their debts a lot sooner if they didn't have to take that 7-year path. And that 7-year path is just for general surgery, 5 to 7 years. If you want to do chest surgery, it's going to take you a minimum of 7 years, possibly 8 if you have to do research. And then, think about all the other things. You still have lots and lots of time that you have to put in where you're making, basically a living wage, but you certainly aren't going to be paying off massive amounts of debt with a, resident salary of $60,000 or $65,000 in this economy today. So yeah, there are many reasons why I think shortening the pathways to the other things. But here's the problem. What happens if somebody gets into chest surgery and realizes, what, I really don't want to do that. Now he's gotten 3 years of general surgery and then a year and a half of chest surgery, and he realizes he doesn't want to be a chest surgeon. Maybe chest surgery, by the way, will disappear by the time, in the next 10 years. Who knows? Because maybe cabbages won't be done, and, valves will be done all, endovascularly, and there won't be much need for chest surgery. A trauma surgeon can put a chest tube in and maybe even resect a lung or a lobe because, many trauma surgeons are capable of doing that. So, maybe there won't even be a need for that. And so what do you do with somebody who's gotten, 3 years plus a couple of years and then says, wait, this isn't working? That's the problem. You better have your mind made up if you're going to do that, because it's going to be very difficult to change, as it is, by the way, already quite difficult to change. But the difference is, if I've gone through general surgery 5 years completely and decide I don't want to be a plastic surgeon or a thoracic surgeon, I can just, I'm a fully trained general surgeon. I can do that. Okay. So, it would be a little bit tricky for those who have, for one reason or another, don't want to finish or don't want to do what it is they got themselves into. So, it has, like everything, pros and cons. Everything has its pluses and minuses. So, but I think that we probably will see some shortening of training, and it would free up cases for people who really want to do general surgery. You look at things like the median number of open common duct explorations done by graduating general surgeons is 1. That's not very reassuring if you have to get in there. Let's say your ERCP guy just can't do it. And then you have to do it, and you've done 1 common duct exploration in your whole 5 years of general surgery. I don't think that's going to work.
Right. Well, there's about 10 topics there we could spin off for another conversation, and I'd like to actually. I think there's a lot.
Well, maybe we can have a regular show. Every week.
I think we're onto something. Well, thanks for your input on these things, but I really would like to get back to do some more and sort of break up those subtopics.
Well, that's fine. I'd be happy to chat with you at any time. Thank you for even asking me. Appreciate it.
Okay, we'll talk again soon. Bye-bye.
Bye-bye.
Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook. Follow us on Twitter. And find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.